Good evening, my dear children. Today we are going to discuss about the nephrotic syndrome. So, nephrotic syndrome is a primary disease. It is otherwise known as idiopathic nephrosis, childhood nephrosis, or minimal change nephrotic syndrome. So, it is a disease known as idiopathic nephrosis, then childhood nephrosis, or minimal change nephrotic syndrome. It is one of the commonest cause of hospitalization among children. So, nephrotic syndrome, it is defined as it is a clinical state that includes massive proteinuria, which is less than 70 mg per dl, then hypoalbuminemia, which is less than 3.4 to 5.4 gram per dl, then hyperlipidemia, that is hyperlipidemia and generalized edema. So, nephrotic syndrome, it is a clinical state that includes massive proteinuria, hypoalbuminemia, hyperlipidemia and generalized edema. So, in normally the protein content in urine should be less than 70 mg per dl, and also the albumin in the blood should be it should be between 3.4 to 5.4 gram per dl. If it is less than that, it is hypoalbuminemia. Then hyperlipidemia, that means if the cholesterol level, especially the LDL, is greater than 110 to 120 mg per dl, and generalized edema. So, these are the classical signs of nephrotic syndrome. It is a clinical state that includes a massive proteinuria, hypoalbuminemia, hyperlipidemia and edema. So, nephrotic syndrome is a symptom complex manifested by massive edema, hypoalbuminemia, marked albuminuria and hyperlipidemia. So, types are congenital nephrotic syndrome, then idiopathic nephrotic syndrome or primary nephrotic syndrome and secondary nephrotic syndrome. So, the categories are congenital nephrotic syndrome, idiopathic or primary nephrotic syndrome and secondary nephrotic syndrome. First is congenital nephrotic syndrome. So, it is rarely seen, but it is a serious and fatal problem. So, usually the congenital nephrotic syndrome is much rare, and it is a serious and fatal problem, and it is associated with other congenital anomalies of the kidney like horseshoe kidney, and it is an inherited autosomal recessive disorder. And the severe renal insufficiency and urinary infection are the manifestations. Severe renal insufficiency and urinary infection. What is renal insufficiency? Renal insufficiency is the inability of the kidney to remove waste and maintain fluid balance. So, that is renal insufficiency. It is the inability of the kidney to remove waste and maintain fluid balance, and there will be urinary infection. And the second category is primary or idiopathic nephrotic syndrome. It is the commonest type of nephrotic syndrome, and it is about 90% of the cases will be primary or idiopathic nephrotic syndrome. It is also because of the autoimmune phenomenon, because of certain immunosuppressive therapy. Because of certain immunosuppressive therapy, there will be autoimmune response in our body, and it will result in primary or idiopathic nephrotic syndrome. So, the main cause of idiopathic nephrotic syndrome is response to immunosuppressive therapy, and it is classified into two, that is minimal change nephrotic syndrome and mesangial proliferative nephrotic syndrome, MCNS and MPNS, that is minimal change nephrotic syndrome and mesangial proliferative nephrotic syndrome are the categories of primary or idiopathic nephrotic syndrome. First is minimal change nephrotic syndrome. About 85% of the primary idiopathic nephrotic syndrome are minimal change nephrotic syndrome. Minimal change nephrotic syndrome means that the kidney will function normally, but the only problem is that there will be excess protein excretion or excess loss of protein through urine due to allergic reaction or use of any painkillers like non-steroidal anti-inflammatory drugs. Okay. So, minimal change nephrotic syndrome, about 85% of the primary or idiopathic nephrotic syndrome are minimal change nephrotic syndrome. This minimal change nephrotic syndrome, here the kidney will be functioning normally, except which there will be excess loss of protein through urine because of any allergic reaction or use of painkillers like non-steroidal anti-inflammatory drugs, tumors or viral infection. Then the next category of primary idiopathic nephrotic syndrome is mesangial proliferative nephrotic syndrome. In mesangial proliferative nephrotic syndrome, there are all the manifestations of nephrotic syndrome like proteinuria, hematuria, edema, then hypoproteinemia, hyperlipidemia, and the cause is unknown. Okay. So, in mesangial proliferative nephrotic syndrome, there are all the classical signs of nephrotic syndrome like hypoproteinemia, proteinuria, hematuria, edema, hyperlipidemia, and the cause is not known. Here, what is mesangial cells? The mesangial cells are stabilizers of the glomerular cells. That means if there is any infection or injury to the kidney, glomerular cells of the kidney, these mesangial cells will regulate the function of the glomerular cells by their activity. But if there is proliferation of the mesangial cells because of any cause, because of any unknown cause, there will be proliferation of mesangial cells, and it will result in the mesangial cell proliferative nephrotic syndrome. Okay, that means the mesangial cell, the normal function of the mesangial cell is to stabilize the glomerulus if there is any injury to the kidney, or if there is any infection to the kidney, especially the glomerulus. But if there, because of any unknown cause, if there is proliferation of the mesangial cell, it will affect the kidney, and it will cause eventually cause proteinuria, hematuria, edema, hyperproteinemia, hyperlipidemia. And next is focal. Then another type of primary idiopathic nephrotic syndrome is focal sclerosis nephrotic syndrome, and it is 10%. Then next, the third category of nephrotic syndrome is secondary nephrotic syndrome. About 10% of cases are secondary nephrotic syndrome. It may occur due to other forms of chronic glomerulonephritis. As the name itself, it is because of the it is a secondary condition as a result of chronic glomerulonephritis, diabetes mellitus, systemic lupus erythematosus, then malignant hypertension, hepatitis B, then infective endocarditis, HIV or AIDS, then drug toxicity, lymphomas, and syphilis. So these are the causes of secondary nephrotic syndrome. So then we are moving on to the pathophysiology. So in pathophysiology, due to the charge selectivity and thickening of the food plate of glomerular membranes. What is charge selectivity? Charge selectivity means there are anions and cations in the kidney which will allow the transfer of fluid according to the change in the charge. Okay, so because of the charge selectivity and thickening, that is there will be thickening of the glomerular membranes. So because of these there will be increased permeability. Okay, there will be increased permeability to protein, especially the albumin. Okay, so actually there is not much permeability to protein, especially albumin. So if the albumin if there is increased permeability, automatically there will be protein loss through urine or hyperalbuminuria. And as a result of hyperalbuminuria, there are two changes, that is reduction of the serum albumin level and infection and immunosuppression. Okay, so there are two consequences because of hyperalbuminuria: reduction of the serum albumin level or hypoalbuminemia, and infection and immunosuppression is the second route. So we can see the first route. After hyperalbuminuria, there will be hypoalbuminemia. So if the albumin is excreted through urine in excess, as a result there will be less albumin in the blood. This will result in the decreased plasma oncotic pressure. So the function of the albumin is to maintain oncotic pressure. So what is oncotic pressure? Oncotic pressure means it is a pressure that is maintained by the albumin in the blood vessels or capillaries. Okay, in the blood vessels or capillaries, this albumin will maintain a pressure known as oncotic pressure. As a result of oncotic pressure, there will be deficiency of water molecules inside the capillaries. Okay, this albumin will create a deficiency of water molecule inside the capillaries, and this will, as a result of this, there will be absorption of water into the capillaries from the interstitial space. Is it clear? Because of the function of the albumin will maintain a normal oncotic pressure. The normal oncotic pressure means the albumin will create less pressure inside the capillaries. As a result, there will be decrease in the water level inside the capillaries, and finally the water will be absorbed from the interstitial space into the capillaries. This is the mechanism to maintain the normal fluid level inside the body. But as a result of decreased plasma oncotic pressure, if there is as you all know, water will flow from the high pressure to the low pressure region. So because of the decreased plasma oncotic pressure, there will be if there is decreased oncotic pressure, flow of fluids from the capillaries to the interstitial space. Okay, instead of flow of fluid from the interstitial space to the capillaries, there will be reverse in the flow of fluid. That is, instead of the flow of water from the interstitial space to the capillaries, there will be flow of fluid from the capillaries to the interstitial space. Okay, as a result of the excessive flow of fluid into the interstitial space, it will result in edema. Okay, then there is another change because of the flow of fluid from capillaries to interstitial space. What is that? This flow of fluid into the interstitial space is mainly to the abdominal cavity. The flow of fluid will be to the interstitial space of the abdominal cavity, and it will result in ascites. Okay. Then next, I have already told you that hyperalbuminuria will cause infection and immunosuppression. As a result of infection and immunosuppression, there will be to compensate with the infection and immunosuppression, there will be increased hepatic lipoprotein synthesis. As a result of this, increased hepatoprotein synthesis is to suppress the infection. As a result, there will be hyperlipidemia. This hyperlipidemia, okay, this is the manifestation that we can see in infection and immunosuppression. So, as a result of infection in immunosuppression, there will be hyperlipidemia. Then another one. Due to hypoalbuminemia, there will be decreased plasma osmotic pressure. There will be flow of fluid from capillaries to the interstitial space. As a result, I have already told you that there will be edema. Then ascites. Then another change that because of the flow of fluid from capillary to interstitial space is hypovolemia. Okay, if there is flow of fluid from capillaries to interstitial space, there will be hypovolemia, and it will result in the renin-angiotensin-aldosterone system. This renin-angiotensin-aldosterone system, because of the hypovolemia, as a result of hypovolemia, there is a tendency to go for hypotension. To maintain this, there will be stimulation of renin-angiotensin-aldosterone system. As a result, as the renin-angiotensin-aldosterone system is getting stimulated, there will be increased production of antidiuretic hormone and aldosterone. And this will result in the increased reabsorption of sodium and water in the distal tubules. That is, because of the accumulation of fluid, to compensate that, there will be production of antidiuretic hormone and aldosterone by the renin-angiotensin-aldosterone system. Because of the increased production of antidiuretic hormone and aldosterone, there will be increased reabsorption of sodium and water in the distal tubules, and there will be renal glomerular damage. Because of the increased production of aldosterone and ADH, there will be renal glomerular damage, and it will result in, because of the damage of the cells. What is a byproduct in the damage of the cells? As a result of the damage of the cells, there will be massive production of protein, and it will cause proteinuria. So automatically, if the protein is lost through the urine, it will result in hypoproteinemia. That means automatically the level of protein in the blood will be decreased and result in hypoproteinemia. And as a result of hypoproteinemia, there are two results. One is increased hepatic synthesis of protein and lipids. Okay, to compensate this hypoproteinemia, the liver will try to synthesize more proteins and lipids, and this will result in hyperlipidemia. Okay, then as a result of proteinemia, there is another change, that is decreased oncotic pressure. As a result of hypoproteinemia, there will be decreased albumin in the blood. As a result of decreased albumin in the level, I have already told you that albumin will maintain the oncotic pressure. So, if the oncotic pressure is decreased, it will result in hypovolemia. As a result of hypovolemia, there will be decreased renal blood flow, and it will cause renin release and vasoconstriction as a result of hypovolemia. Then, as a result of hypovolemia, there is another change, that is increased secretion of aldosterone. Okay, so decreased oncotic pressure because of hypoproteinemia as a result of massive proteinuria, there will be hypovolemia, decreased oncotic pressure, then hypovolemia. Hypovolemia will cause the decrease of renin and increased secretion of aldosterone. Because of the increased release of renin, there will be vasoconstriction, and because of the increased secretion of aldosterone, there will be sodium and water reabsorption and increased hydrostatic pressure. Hydrostatic pressure will be increased, and it will result in edema. And the oncotic pressure decrease will also cause shift of fluid from the capillaries to the interstitial space. I have already told you that in oncotic pressure, if the oncotic pressure is decreased, there will be shift of fluid from capillaries to interstitial space, and it will cause edema. Okay, and also we can see that if the increased production of ADH and aldosterone, there will be edema. So it is there is a reverse route also. So it is a complex pathophysiology. If you have any doubt, you can ask me. Then clinical manifestations: weight gain, then puffiness of the face, that is facial edema, especially around the eyes, that is periorbital edema. Then it is arising in the morning. This edema is arising in the morning and subsides during the day. And then abdominal swelling or ascites, then pleural effusion, then labial or scrotal swelling, then edema of interstitial mucosa, possibly causing diarrhea, anorexia, poor intestinal absorption, ankle or leg swelling, irritability, easily fatigue, lethargic. Then BP will be normally or slightly increased. Then susceptibility to certain infections, then urine alteration like decreased volume of urine or frothy urine, then hepatosplenomegaly, hematuria, then hypertension and wasting of muscles because of the wasting of muscles is because of the less sodium absorption. Then diagnostic evaluation, history collection, then physical examination, all signs and symptoms can be manifested. Then lab investigation, urine examination show gross proteinuria, that is 2 to 20 gram per day, then presence of cast, then slight hematuria and increased specific gravity. Then that is the specific gravity will be 3 plus. Then the gold standard in diagnosis of nephrotic syndrome is 24-hour urine protein measurement. We can collect 24-hour urine and we can assess the how much protein is losing per day. That is a golden standard of diagnosis. Then blood examination shows decreased serum protein, albumin will be less than 2.5 gram per dl, cholesterol will be more than 200 mg per dl, specifically elevated LDL. LDL will be elevated. Then lipoprotein and BUN are increased. Then serum albumin and globulin ratio are reversed. Then platelet count may be increased. Serum sodium level is decreased. Then decreased creatinine level. Then ASO titer is elevated. That is anti-streptolysin O titer. That is if there is any presence of infection, with the anti-streptolysin titer will be elevated. It is the antibody detection test. Then IgM decreased. Increased IgG and IgE. Then renal biopsy is indicated if there is no response to steroid therapy for 4 to 8 weeks. We will wait for up to 2 months if the child is having a response to steroid therapy. If there is no response, we will go for renal biopsy to rule out any malignancy. Then management, objectives of the management are reducing excretion of urinary protein, reducing fluid retention, preventing infection, minimizing complications. The dietary restriction include low salt diet, fluid restriction, high protein diet. Then diuretic therapy to reduce the massive edema and ascites. Furosemide 1 to 3 mg per kg per day in 2 divided doses alone, or with spironolactone 2 to 3 mg per kg per day in 2 divided doses is given as a diuretic. Then rapid fluid loss should not be attempted within 8 to 12 hours. We should not allow rapid fluid loss. Then potassium supplementation to be given along with diuretics because of the loss of potassium along with the urine. Then acute infection are treated with appropriate antibiotics. Then steroid therapy with prednisolone is a first line therapy. First line therapy is steroid therapy with prednisolone. Starting dose is usually 2 mg per kg per day. Then usually response within 7 to 21 days. It is continued for at least 4 to 6 weeks and then gradually tapered over a period of several months and eventually stopped if the child is remaining asymptomatic. So we have to treat up to several months. Then albumin infusion, 25% albumin is infused 1 gram per kg per day, may be given in the case of massive edema and ascites. Then immunosuppressive drugs like levamisole, methotrexate, cyclophosphamide, cyclosporin, then chlorambucil may be administered along with prednisolone if there is any relapse. Then renal transplantation is indicated in the end-stage renal failure due to steroid-resistant glomerulosclerosis. In some cases, there will be they may develop steroid-resistant glomerulosclerosis, and in that case, complete renal system will be damaged, and in such cases, renal transplantation is indicated. The nursing management include continuous monitoring of fluid retention or excretion, maintain intake-output chart, maintain urine examination for albumin, daily weight and measurement of abdominal girth, then assessment of edema, vital sign monitoring, decrease infection, then adequate nutrition by reducing salt and fluid restriction, then serve preferred food in attractive manners, then provide suitable recreational activities. In complication are ascites, then pleural effusion, generalized edema, then coagulational disorders, thrombosis, then recurrent infection of the different systems, then renal failure, then growth retardation, calcium and vitamin D deficiency, protein energy malnutrition, relapse of nephrotic syndrome. Thank you. Hope you all understood the topic well. If you have any doubt, you can ask me. Thank you.